Treatment of acute promyelocytic leukemia. So, in the treatment of acute promyelocytic leukemia, if we take this acute promyelocytic leukemia, so this acute promyelocytic leukemia, so this is a highly curable AML subtype. Okay, so if we take acute promyelocytic leukemia, it is a highly curable AML subtype, and 85% of these patients they achieve long term survival. Okay, what is the percentage of patients who are achieving long term survival? So it is 85% of these patients, so they are achieving long term survival. So this has been shown to be responsive to cytarabine and daunorubicin. APL. So this was responsive to cytarabine and daunorubicin. But in the past, what happened was patients who were treated with the cytarabine and daunorubicin, so they died frequently from DIC. Patients who were treated past with cytarabine and daunorubicin, they died from DIC because of the release of the granule components by the chemotherapy treated leukemia cells. So those patients were treated with cytarabine and daunorubicin. So because of the treatment of this acute promyelocytic leukemia by cytarabine and daunorubicin, so what happened was there were release of the granule components from these chemotherapy treated leukemia cells, and patient developed DIC and patient died due to DIC. But the prognosis of APL patients, it has changed dramatically. Why? Because the prognosis of APL patients has changed dramatically because of the introduction of the tretinoin. Okay, so what is this tretinoin? So this is all trans retinoic acid. So this all trans retinoic acid, so this is an oral drug. So this induces the differentiation of leukemic cells bearing the T1517. All trans retinoic acid, it is a oral drug. So what does this drug do? So this drug causes differentiation of the leukemic cells bearing the translocation of the chromosome 1517. So because of this, there will be a disruption of the RARA gene, which is encoding a retinoic acid receptor. This will occur. So this oral drug is all trans retinoic acid. So this induces the differentiation of leukemic cells, and it also causes disruption of the RARA gene. So disruption of the RARA gene, so which, because it was encoding a retinoic acid receptor, and this ATRA, so this drug, this decreases the frequency of the DIC. But with this drug, okay, with chemotherapy, what is happening? So there was DIC, but if we use this ATRA, it produces another complication. So what is this another complication? So this is called as APL differentiation syndrome. Okay, so what is the other complication with this drug? So this is APL differentiation syndrome. So what was a complication with chemotherapy treated leukemia cells? It was DIC. So what is the long-term survival with this in the long-term survival with this type of promyelocytic leukemia? It is 85%, and so this is highly curable. And so what is this APL differentiation syndrome? So APL differentiation syndrome, so this occurs within the first 3 weeks of treatment. When does this APL differentiation syndrome occur? So this occurs in the first 3 weeks of treatment. So how is it characterized by? So this is characterized by fever, fluid retention, dyspnea, chest pain, pulmonary infiltrates, pleural and pericardial effusions, and hypoxemia. What are the complications of this differentiation syndrome. So this APL differentiation syndrome, so this occurs in the first 3 weeks of treatment. So how is this syndrome characterized? By fever, fluid retention, dyspnea, chest pain, pulmonary infiltrates, pleural pericardial effusions, and hypoxemia. So this syndrome, no, so this is related to, why is this syndrome occurring? So this syndrome is related to adhesion of the differentiated neoplastic cells to the pulmonary vasculature endothelium. So this syndrome is related to, what is happening in this syndrome? Adhesion of the differentiated neoplastic cells to the pulmonary vascular endothelium. So there is pulmonary vascular endothelium. These cells are going and adhering. So these neoplastic cells are going and adhering to the pulmonary vascular endothelium. And glucocorticoids, chemotherapy for cytoreduction, and supportive measures. So these are effective for the management of the APL syndrome. So what are effective for the management of the APL syndrome? Glucocorticoids, chemotherapy for cytoreduction, and supportive measures are effective for management of the APL syndrome. Temporary discontinuation of all trans retinoic acid is necessary in cases of severe APL syndrome. So when should we temporarily discontinue this all trans retinoic acid? So this temporary discontinuation of all trans retinoic acid, it is necessary in cases of severe APL syndrome. What is this severe APL syndrome? Patients developing renal failure or patients requiring admission to the intensive care unit due to respiratory distress. So when can we say that patient has got severe APL syndrome? That is when patients are developing renal failure or patients who are requiring admission to the intensive care unit due to respiratory distress syndrome. And what is the mortality rate of these patients when the syndrome occurs? So the mortality rate will be 10%. And acute promyelocytic leukemia syndrome may also occur less commonly with arsenic trioxide in APL. So this syndrome, it is more commonly seen with all trans retinoic acid. So this syndrome, it also occurs with arsenic trioxide, but it is less common with arsenic trioxide. So what are the things? Why is this syndrome occurring? Because of the adhesion of the differentiated neoplastic cells to the pulmonary vascular endothelium. So what are effective for the management of this APL syndrome? Glucocorticoids, chemotherapy, and supportive measures. And with arsenic trioxide also this syndrome occurs, but this occurs less commonly. And then we have this in adults with low risk APL. So when do we say that patients have this low risk APL? That is, who are having this low leukocyte count at presentation. In adults with low risk APL, that is, who are having the low leukocyte at presentation. So if we use this all trans retinoic acid plus arsenic trioxide, this is better. Okay, so this is superior compared to all trans retinoic acid plus concurrent idarubicin chemotherapy. Low risk APL, that is low leukocyte count at presentation. So then what we have to give? All trans retinoic acid and arsenic trioxide. So this all trans retinoic acid and arsenic trioxide, so this is superior compared to using all trans retinoic acid and concurrent idarubicin chemotherapy. And complete remission rates in low risk disease approach 100%. So if patient is having this acute promyelocytic leukemia, which is of low risk, so the complete remission rates in low risk disease is 100%, and patients will also have a excellent long-term survival. But patients who are having this high risk APL, okay, high risk APL means patients who are having a leukocyte count greater than 10,000 per microliter, they must be uniquely treated. Why they should be uniquely treated? They require immediate cytoreduction with chemotherapy due to life-threatening APL syndrome and rapidly rising leukocyte count after initiation of all-trans retinoic acid. So, if patients are high risk acute promyelocytic leukemia patients, high risk means acute promyelocytic leukemia where these patients are having leukocyte count greater than 10,000 per microliter. They should be uniquely treated because these patients, no, instead of giving this all trans retinoic acid and arsenic trioxide, they require immediate cytoreduction with chemotherapy. Because if we give this all trans retinoic acid, so this will cause rapidly rising leukocyte count. And high risk patients, they are at increased risk for induction death due to this syndrome, as well as increased frequency of hemorrhagic complications. So they'll have this induction death due to the syndrome after initiation of ATRA, and they also will have a increased frequency of hemorrhagic complications, so which are related to a disseminated intravascular coagulation. And after giving a final cycle of treatment, okay, what we have to measure is, we have to measure the residual disease activity. So how are we measuring the residual disease activity? So we are measuring the residual disease activity by RT-PCR amplification of the 1517 chimeric gene product. So what is this 1517 chimeric gene product? PML RARA. So we have given treatment and we have to know whether residual disease is present or not. So how do we know that residual disease is present or not? Because we have to measure a 1517 chimeric gene product. So what is this? So we are measuring the PML RARA. So if the disappearance of this signal, so this is associated with long-term disease-free survival. We are measuring this PML RARA. So if there is a disappearance of this PML RARA, so this is associated with a long-term disease-free survival. If this PML RARA persistence or a re-emergence, if we have noticed that PML RARA on doing this RT-PCR, if there is a persistence or if there is a re-emergence, so what it invariably predicts that disease has relapsed. So sequential monitoring of RT-PCR for PML RARA, so this is now considered the standard for post-remission monitoring of APL, at least in high-risk patients. So after giving treatment in high-risk patients, what we have to do? We have to do a sequential monitoring of RT-PCR for PML RARA. So this is now considered a standard for post-remission monitoring of the APL patients, at least in high-risk patients. And patients in molecular, cytogenetic or clinical relapse, they should be salvaged with ATO with or without all-trans retinoic acid. So patients patients still they have this molecular, cytogenetic or clinical relapse. Relapse can occur in any way, either it could be clinically, cytogenetically or molecular. So how should these patients be managed with? So these patients should be salvaged with arsenic trioxide. In patients who were treated with all-trans retinoic acid plus chemotherapy in the frontline setting. So how should see, patients are there, patients having molecular, cytogenetic or clinical relapse. How should they be salvaged? They should be salvaged with arsenic trioxide with or without ATRA. In patients who are treated with ATRA plus chemotherapy in the front line setting, arsenic trioxide based therapy at relapse produces meaningful response in up to 85% of the patients. So initially, in high risk patients, this combination is also used, all-trans retinoic acid plus chemotherapy. So if we have used this all-trans retinoic acid and chemotherapy in the front line setting, then arsenic trioxide based therapy at relapse, if we give this arsenic trioxide, it produces so this produces meaningful responses in 85% of the patients. Although experience with relapsed acute promyelocytic leukemia in patients who received all retinoic acid during initial induction is limited. And all arsenic trioxide, okay, patients experience, see, initially if patients are treated with all-trans retinoic acid and chemotherapy, for relapse we can give this arsenic trioxide. But the experience with relapsed patient, they have already received they have already received arsenic trioxide during initial induction, no? So if those patients relapse, the experience is limited. So arsenic trioxide, so this remains the preferred reinduction therapy for patients who relapse, although the duration of prior remission should be a factor in this choice. And if there is a achievement of a complete remission, okay, so this should be followed by consolidation with autologous hematopoietic stem cell transplant for patients who achieve RT-PCR negative status. So patients, they have achieved the clinical remission, okay. So this should be followed by a consolidation with the autologous hematopoietic stem cell transplant. And patients who do not achieve this negative RT-PCR or patients who relapse again, what should be the treatment? So treatment should be allogenic hematopoietic stem cell transplant. So first we are giving treatment. Patients who are relapsing arsenic trioxide, and then again we are measuring the RT-PCR of PML-RARA, and again patients, if they have relapsed, if they have achieved complete remission, then we have to treat with autologous hematopoietic stem cell transplant. Who do not achieve this negative RT-PCR, again we have to give this allogenic, we have to treat the patient with allogenic hematopoietic stem cell transplant. So that is about the treatment of the